All right, so the first topic that I decided to touch base about with you guys as a group from an observation standpoint is not our most common admitting diagnosis, but it's pretty common. And I've worked recently with the neurology team and stroke teams at both sites to develop a TIA pathway. So I thought it just made sense to start with this because it will be one of the first pathways that we will have rolled out. First, I just want you to think as we go through this lecture, think about these two cases and what you would do in those for these patients that I'm putting out there for you. The first is a 68-year-old gentleman with a history of hypertension, hyperlipidemia, diabetes, who's coming in after he suddenly had focal left upper extremity weakness while he was eating dinner. He said it was there for about 15 minutes and then started to go away over time. And by the time EMS got there, it really was gone. He's a little hypertensive, but really had a completely normal examination when he got to the emergency room. And the second case is a younger gentleman, a 38-year-old guy, no medical history. He says he had this sudden onset of dizziness and felt like he was walking really unsteady, like he was drunk. He said it lasted about 30 minutes. It's now completely gone. But the thing that he still has, and he's had for some time, is this really bad left-sided headache in the occipital region that's been there for about 2 days. And also his vitals are pretty unremarkable and he has a completely normal exam when you see him. So I want you to think about these cases a little bit as we go through everything and think about what you would do for this patient, if there's any risk stratification tool you might use, and your disposition. So today we're going to kind of go through TIA, what it is, what the definition is, what things you're looking out for, what is on your differential diagnosis, and most importantly, and where we're going to spend most of the time today, is talking about what the underlying causes are of TIA and what the workup that you would do to find these causes or to try to at least look for them. We'll talk a little bit about risk stratification and the choice of dispo, and then treatment and prevention. And then we'll go through the pathway that I have coming out shortly. I have, this is kind of the whole encompassing patient experience from the time they come to the emergency room through the observation unit, because I don't think you can fully understand one without the other. So by definition, a TIA is a transient episode of neurologic dysfunction caused by a focal brain, spinal cord, or retinal ischemia without acute infarction. So previous diagnosis used to include a time frame, like less than 24 hours. But now that we have MRI so readily available, the definition really includes if there is nothing on imaging, nothing on an MRI, and it sounds like a TIA, it's a TIA. If there's something on the imaging, then the definition is stroke. And if at any point anyone has any questions, this is completely informal. Please, unmute yourself and stop me, or you can throw it in the chat if you prefer that. Okay, so this is the first poll question. And I think it's open. So what is the risk of stroke after an ED visit for a TIA? So if a patient comes in, you diagnose them with TIA, what is their risk of stroke in the next 48 hours? So again, the information's at the top there. The number is 22333 that you would text, that you would put in, like if you were texting your friend, that's their name. And then you put B Brown 040. And then, and then it's A, B, C, and D. So do you think their risk is 0.5%, 1.3, 4.8, or 6.7? So this is for all comers, no matter what their risk factors are. All adults. I know there's more than 3 of you. Let me get like 1 or 2 more. Okay, and it might not be working for everyone, but if it's not working, let me know in the chat. But we have some responses. So 1.3%. You guys are going to be a little shocked. I actually was, because I didn't even know this till I put together this lecture, which I'm a little embarrassed to admit, but it's actually 4.8%. for all comers. And that's pretty high. I mean, almost 5% your risk of having a true stroke in the next 48 hours. That's pretty concerning. So, that is why when these patients come to the hospital, I think a lot of the times that we're taking it seriously, and we want to make sure that there's nothing we can do to prevent this risk of stroke in the next 48 hours. And also, obviously, their long-term risk as well. For people that do present to a hospital with an ischemic stroke, when you talk to them, about 15% of them will say they had TIA-like symptoms prior to this acute event. So history and physical, we're not going to go into this much. I mean, we already said by definition, a TIA is a transient neurologic event. And by the time you see them, their physical exam findings should be gone, unless, they get there right away. And it's only been 10 minutes since their symptom starts, but realistic.
Hey, Bonnie, your sound cut out. I don't know if
crap.
it's just for me.
Okay, where did it
now
cut
I can
out?
hear you.
Sorry.
This slide, yeah, at this slide.
Okay, yeah, okay, sorry about that. And let me know if it
No
does it again.
worries.
It might be my headphones. It's just, I can't hear if I don't have them on.
It's okay.
I'm an old lady. So the misdiagnosis rate in the emergency room is about 60%. I don't think that anyone should get down on themselves about this. This is because specialists in retrospect are talking to these patients and going through chart review and disagreeing with the diagnosis, but they have all the imaging results and everything else. So, but it is highly misdiagnosed, but our job is to at least try to capture the ones that sound like TIA and work them up appropriately. You want to look for associated symptoms. So just something to think about. Strokes and TIAs, they present with negative symptoms most of the time. Loss of function. So they've got weakness of an extremity, or their speech is messed up because they have weakness of the vessels around the mouth, or their tongue. They've got numbness or loss of sensation or blindness. It's really rare to have a stroke or a TIA present with a positive symptom like a seizure or tingling or flashes of light. So that's just something to keep in mind when you're evaluating these patients. It's not impossible. I guess you could have some sort of a small little seizure along with it, but it's pretty rare. So negative symptoms are just much more suggestive of something that's truly ischemic. Okay, so for those of you that have pull everywhere up, just text in an underlying cause of TIA, something that you know is a risk factor or a cause of TIA. Get out of there. Sorry. Okay, good. Yeah, hypertension's a risk factor, definitely. Smoking, definitely. Diabetes, yes. What is one of the big causes that we always, why do we do an EKG if someone presents with a TIA or a stroke? Fib, yes, atrial fibrillation. So that's a really big risk factor. Okay. So the underlying causes that we're looking for, atrial fibrillation, A-flutter, do they have some sort of an intracardiac clot? So in AFib, they can get obviously atrial clots, and that's what causes them to have these strokes and TIAs and why they're on anticoagulation. People with really bad CHF, sometimes they will have clots in the ventricles as well. So if for some reason this person has a really bad had bad heart failure, something to think about is they could have some sort of a clot in their ventricle. Patients that are IV drug users or for other reasons might have a higher risk of endocarditis. It's definitely something to have on your radar because they can have these little thrombi that go off and cause TIAs or stroke symptoms. Atrial myxomas, which are not common, and to be honest, I've never seen it, but just something to think about. If someone has a PFO, so the patent foramen ovale, then they're obviously at a higher risk. And in some patients, we are doing the echo with bubble study to evaluate for this, but I'll talk about that in a little bit. And then if they have intracranial or extracranial atherosclerosis, so do they have carotid stenosis or vertebral artery stenosis? That's a huge risk factor for them having TIAs and strokes. And then carotid dissections also on that differential. And it's really something to think about, especially in younger people, that you're like, it's weird. This person shouldn't have risk factors. And they're like, oh, I just had chiropractic and on my neck. And I don't know, just it's something to think about. And we do see it every once in a while. And we'll talk a little bit more about risk factors for that. This we've already pretty much kind of gone over. Some of the common mimics are migraines, and if they had a seizure and maybe it wasn't witnessed, but now they have Todd's paralysis afterwards. So those just other things on your differential to think about. And so if anyone wants to, actually, I think I have a scatter plot, so I don't have to call anyone out. What would your initial workup for TIA be when a patient presents? I know everyone knows this. Yeah, EKG, CT head, I think, yeah, CTA, head and neck. Yeah, I think those are perfect starting points. So I think that anyone that's coming in with anything neurologic, we always will do a finger stick with an EKG, ideally a triage. In an ideal world, if you have room, you would put the patient on telemetry in the emergency room on the monitor. So at least if they do have an arrhythmia, maybe you'll be alerted to it. You want to do basic labs, check for electrolyte abnormalities, and then the imaging, which is the next thing we're going to talk about. So the whole point of a workup is looking for underlying causes, because you have a perfectly normal looking patient right in front of you. So you're not trying to fix an issue, but you're trying to look for an underlying cause that maybe could help save them from having a stroke in the future. So you want to look at the brain. So you want to do either a CT head non-contrast or an MRI brain. If they still have any persistent symptoms or findings, then you need to do that CT head first, obviously, because that's going to be much faster than getting your MRI. We're looking for arrhythmias, so that's your EKG and your telemetry. You're looking for this atherosclerosis or even the carotid artery dissection or vertebral artery dissection, and that's going to be with your vessel imaging, which is why it's a lot of these times we're like, well, the patient looks good, maybe I'll just do a CT head. They really need vessel imaging as well. So CTA head and neck, or the MRA head and neck, or carotid ultrasound, which I'll talk in a little bit just about the sensitivity of that and why it's not preferred. And then other cardioembolic causes, you want to make sure that you're thinking about these other things in the differential. Like if they have a new murmur, maybe they have endocarditis. Do they have signs of CHF? Do they also have a fever? Those are other things that will make you say that you also want to do further cardiac workup for these patients. So a little bit more about the cardiac evaluation. About 20 to 25% of all TIAs across the board are from atrial fibrillation, and that includes patients that have known atrial fibrillation. About 2% of patients that present with TIA that there is a reason found behind it. It's the reason is new diagnosis of atrial fibrillation. So if you have a patient that comes in and their EKG is fine, they don't have cardiac history, they don't have any signs of CHF or a new murmur on exam, less than 3% of them are found to have anything on an echo. So you do not have to do an echo on every single patient that presents with a TIA. All right, so who does need it? The people that do need the echo are the ones that you are worried that they could have some sort of intracardiac thrombus. So these severe CHF, the AFib, maybe they weren't on anticoagulation, or they have a murmur and you're worried about some sort of valvular disease that's acute. And then you might want to consider it in people that have no other explanation. And it really does sound like a classic TIA. And the reason for that is maybe you want to look and see if they have a PFO. All right, and so going on to the brain imaging, I think we all know a CT scan happens really fast. So that's probably your best choice in the emergency room for these patients. The cons to doing a CAT scan is obviously that there's radiation associated with it, and it's not great at viewing the cerebellum or brainstem lesions. However, a CAT scan is important if you're looking for acute stroke or a bleed. So I think that every patient coming in with a TIA, we're probably going to do a CT head unless you can get the patient up to MRI really fast. The benefits to MRI is it's obviously more sensitive, but it's a very slow and resource intensive modality, especially in the emergency room. And if they have any contraindications like metal in the body or something that's not, that they're unable to get the MRI, then obviously you can't use that modality. For TIAs, the MRI is most sensitive if done within the first 24 hours, and patients that had symptoms that were over 6 hours are more likely to end up having an MRI abnormality. So if they tell you that they woke up at breakfast and their left leg was weak and they decided to come in at 5 p.m., but now it's gone, but it lasted for like 6-7 hours, they probably had a true stroke, and you're probably actually going to find something on that MRI. All right, so this is a chart that just goes through the sensitivity and specificity of your different modalities to look at their blood vessels. So carotid ultrasound, as you can see, is much less sensitive and specific than the CTA or the MRA. The other big problem is you're only looking at the cranial vessels. So you're not able to see if they have any significant stenosis intracranial. So you're not really doing the complete workup because really you're only looking at the carotid arteries specifically. Now, that is probably where you care most about, but it's also good to know what's going on inside the blood vessels in the brain. So that is why I really want to talk about coronary CTA. The CTA head and neck is going to be my test of choice for patients presenting to the emergency room because it is the most sensitive and the most specific, and it's the fastest. If the patient has some sort of a contraindication to contrast, or they can't get the CAT scan for whatever reason, then MRI is the best choice. And the other thing is
Bonnie, your sound is skewed again. No.
Okay, is that better?
Yes.
All right, we'll try that, and hopefully that will work out okay. Did you hear any of this slide?
No. Well, not for me, at least, but no.
Okay. Thank you for letting me know. So for the carotid ultrasound, well, I'll just start this slide over. It is not, the reason we never do it, for those of you that are here and work in RE2, we don't do carotid ultrasound for good reason, because you're not actually able to have any evaluation of the intracranial blood vessels. So you're only doing half of what you need to look at. It's great to look for carotid artery stenosis. You may pick up a dissection, but it's really not that sensitive or specific. So the test of choice is going to be your CTA head and neck, which is 100% sensitive and 95% specific. So it's a great test. And unless there's a contraindication, this test should be done as part of your initial emergency room evaluation, because you might find something with that. You might find that carotid artery dissection. You might find, a very significant stenosis. And those patients with significant stenosis should be admitted to the hospital with an evaluation by vascular, because they're at a really high risk of another TIA or stroke. MRA is also MRA head and neck, which is without contrast, is a good choice, but it has the same problems as the MRI brain in that it takes a long time. If you add on the MRA head and neck to your MR brain, you're putting that patient's going to be on the MRI table. I think it's for another 45 minutes to an hour, in addition to the MRI brain. So, it's really not a good use of resources. We only have one MRI machine at each hospital. So really the patient should be getting the CTA head and neck in most cases. All right. So we're just going to kind of move on to what the next steps are. So if you find something in your evaluation, you know what to do. If you find an acute stroke or bleed, you're going to call the appropriate services. If you have a carotid artery stenosis, which the numbers that you care about, which is almost for any sort of arterial stenosis anywhere, is if it's over 50%, you want a specialist to look at it. So that's same with the coronary CTA for these patients with chest pain. If it's over 50%, then you want the cardiologist to be aware. Same thing with carotid artery stenosis. If it's over 50%, neurology and the vascular service or endovascular service, depending on neuro preference, should be on board. And if it's over 70%, that's really significant. And these patients really should have urgent evaluation for definitive management, which the picture down here on the right is the carotid endarterectomy. They actually go in and take out that plaque. And in some patients, it might be better idea to do the artery stenosis, and that will depend on the preference of the vascular team. And for the dissection, which can be either your carotid, your internal carotid, or your vertebral artery, you want to just, I mean, to have these things on your radar, you think of things like trauma, even minor trauma, if they have connective tissue disorders like Marfan's disease, or if they have really bad known atherosclerosis, they're definitely at a higher risk of having a dissection. So the treatment for that, which is anticoagulation, antiplatelets, aspirin, that kind of stuff, and they might need a stent placed if it's really bad, because the dissection, as you can see in this picture, really narrows that lumen. So they might have decreased blood flow to their brain for an extended period of time. So those definitely need a stat, stroke, and vascular consult as well. So if you catch this in the emergency room, that's great. If you don't do the imaging for the CTA head and neck in the ER, then we have made that diagnosis in the RE2. So it's fine, but it's a bit delayed. So really, ideally, you would have that vascular imaging from the emergency room. And then PFO, just something to know about. There are a lot of studies over the past couple of years that have shown significant benefit to closure of the PFO to prevent recurrent strokes in patients. So these patients, if you find a PFO, they don't have to necessarily stay in the hospital, but you do need to make sure you're arranging follow-up for them to be assessed to get this fixed outpatient. All right, so once the patient comes to the OBS unit, you guys know what to do. You look and you say, what already happened? If the patient only had a non-contrast head CT, then you know that the next step is we need to image their vessels, either with the CTA head and neck or MRA head and neck if for some reason they can't get a CAT scan. You would go through all of those things we talked about, the patients that might need the echo with bubble study, and then you're gonna do the MRI brain for the patients that are the intermediate and higher risk. Most of the patients that end up in the observation unit are going to get that MRI brain, just so that you can make the right diagnosis. Is it TIA versus stroke? So even though they don't have symptoms, they still might have had a stroke on their MRI. And then they should be on telemetry just to look for these arrhythmias that might cause them to have atrial clots. Or you can refer them outpatient for cardiology, and they might want to consider doing something like an event monitor or Holter long-term. So I only wanted to mention the ABCD2 score just so that everyone's aware of it, which is, this calculates your risk of stroke after a TIA from the emergency room. So it's based on age, if they're over 60, if they're hypertensive, so B is the blood pressure, C is the clinical features. So you get the most points if you have weakness. If it's just speech disturbance, then you get 1 point, and everything else, which really mainly is all these sensory deficits, doesn't get any extra points. And then duration, if it's over an hour, you get the most points. And if they have diabetes, then you get an extra point for that too. So it is a validated score that tells you what your 2-day risk of stroke is. So you can see here that if you've got a score of 0 or 1, your risk is less than 1%. These are the patients that probably are presenting. They're probably like 35 years old with no medical problems, that said like their whole face was numb for 10 minutes. So it doesn't even sound like a TIA to begin with. These are the patients that probably don't really need any further workup and can be discharged. Once you see that your score is getting up there to like 4 or 5, I mean, that's 4.1%. That's pretty high. And then more than that, the risk of stroke is 8%. I'm going to just kind of skip through this, but I just wanted you guys to be aware of it. and that there is, I will send out my slides. There are ACEP policies and also the American Heart Association and Stroke Association policies, pretty much that recommend based on the ABCD2 score if it's safe to discharge the patient or not if it's low. Sorry. Someone's calling me, I have to decline it. Okay. And the most important thing is if you find anything, if you find any atherosclerosis, is trying to reduce their risk of stroke moving forward. So even if you did all the workup and it just shows like microvascular disease, or maybe they do have a little stenosis of their carotids, the best thing you can do for these patients is start them on medications like aspirin and statin to decrease their risk. If all of the secondary stroke prevention stuff is done, then you can decrease their risk of stroke by up to 80%. So that's starting aspirin, starting statin. If they smoke, telling them to stop, start exercising. If they don't, get their blood pressure better controlled. If they have AFibs, making sure they're on anticoagulation. And if you find something in their blood vessels, making sure they're seeing the right people. All right, so back to our first guy. The 68-year-old that had left upper extremity weakness for about 15 minutes. What imaging would you do? So the first is none, send them home. The second is B is CT head. Oh, sorry, I forgot to hide the results. But CT head and CTA head and neck is the right answer. So great. All right, and so you did that. You did your CT head non-contrast. You did your CTA head and neck. It was negative. You've been watching him for like, let's say 3-4 hours. The tele's fine. He hasn't had any new symptoms. What would you do? Would you send him home with neurology follow-up? Would you put him in the OBS unit or would you admit him? I would put this guy in RE2 too. And my reason being is simply because his workup's not quite done. He's older with a lot of risk factors. I think if you calculated his ABCD2 score, it'd probably be closer to 7. So this is a guy that probably should be monitored for a little bit, probably should get that MRI and just further risk stratification. All right, case 2 is the younger guy who had this episode of dizziness and walking like he was drunk. And he's just got this really bad, like left-sided occipital headache and neck pain for a couple of days. That's still there. So hold on, let me clear and, okay. So for this guy, what would you do in the emergency room? Would you do nothing? Would you do a CT head only? Would you do a CTA head and neck with CT head, or would you do an MR brain only? All right, we don't have a lot of time, so I'm just going to click show responses. The reason we don't have a lot of time is because I have free Zoom. I'm sorry. We only have 10 minutes. All right, so for this guy, and I didn't give you guys too much information, what you go back and you decide, you know what, he's young, but I don't like, you know, he seems really reliable. I don't like how he says he really was like, couldn't walk that well and felt really dizzy. I would do a CTA head and CTA head and neck. And the reason being is because he could have a carotid artery dissection or a vertebral artery dissection. So that is, you know, in this person, what I was trying to describe with the neck pain and the headache is that he could, that's something to think on your differential diagnosis, is that he could have a dissection. And he did. I want to show you guys the TIA pathway. Before we go. Oh, I have it open here. Can you see my my computer screen?
Yep.
Okay. So this is going to start in the emergency room. From the emergency room standpoint, it's not fully, you know, it still has to, it's being reviewed by an external person right now. But from the RE2 side, we can use ours, which is pretty much saying that it's exactly what we discussed today, which is you're going to do the MR brain if it hasn't been done. If the vessel imaging wasn't done in the emergency room, then we're going to complete that. I developed this along with neurology. They really would like a lipid panel and A1C on everyone, so we can just add those on to the previous labs. And you're considering the echo. You don't have to do it on every patient, and they'll all be on the tele. supposedly, depending on where they're boarding. And pretty much it just goes through. If the imaging is positive, then you're going to talk to stroke. They'll be admitted they have a stroke. If the imaging is negative and they've had no recurrence of symptoms, then they can be discharged. So this isn't actually, in my opinion, a deviation from what we do. The goal of this pathway is to streamline the care and make sure that all patients that are presenting with TIA are getting good, appropriate workup from the door. All right. So I want to open this up. We have a few minutes. Does anyone have any questions? I know that was a lot of me talking. I'm sorry. I wanted it to be more interactive. I just wasn't sure how many people would be here. No questions?
That was awesome, Bonnie. No questions.
Yeah,
Yeah,
I really
it
like
was
the questionnaire.
much appreciated. But Bonnie, I do have a quick, small question.
Yeah.
In regards to like the carotid ultrasounds, you know, if
Yep.
like MRI and CT is contraindicated, we can use it, correct?
100%. Yeah, it's definitely better. Yeah, it's still good to do it because like I said, the most likely thing you're going to find in your vessel imaging is something in either the carotid artery or the vertebral artery, honestly, the carotid artery mainly. And so you're going to get that's the biggest bang for your buck is by looking directly at that carotid artery. It's just to note that like it's inferior to the other two because it's incomplete. And also it's not as sensitive or specific. So I generally don't do it, but if the other two are completely contraindicated for whatever reason, then it's definitely worth looking at.
Sorry. Yeah, noted, because that's what I do with some patients. Because sometimes in the ED, when I get them in the middle of the night, an MRI safety screen is not done, so they don't know that they can't. Sometimes if a patient has metal in their body and they can't get it done, the ED doesn't know that. And also with the contrast, if they didn't do a CTA head and neck, then they wouldn't know that, you know, okay, contrast is also contraindicated. So I'm always left with a repeat CT head and carotid ultrasound. So I just wanted to make sure that was still like an option just in case.
Yeah, we can definitely do it. And it will get done during the day.
Okay. Thank you.
Yes. Sorry, guys. I know TIA is a little boring. I didn't want to start with it necessarily in my first lecture, but I hope that this at least clarifies a little bit about the workup and what we do and to help kind of standardize it across the board. No other questions?
No.
All right, guys. I have a website that I put together for this educational series, and I will upload these slides along with the resources that I sent out. And it's kind of going to be a place where just everything will live for right now. And I'm going to continue to do these lectures once a month. Please, any suggestions, comments, questions, email me so that I can improve it next time. And any feedback, let me know.
Thank you.
Okay,
Thanks,
you're
Bonnie.
welcome. You're welcome. Bye,
Thank you.
guys.
Thanks, Dr. Brown.
You're welcome.